this opportunity to speak on the very common problem, yet an important one, which is in a BPH. And I bring greetings from my parent institute, Jamia Hamdard Institute of Medical Sciences and Research. Yeah, so basically it's a patient education program, and it's masterclass on benign prostatic hyperplasia. Well, brief introduction about me. Myself, Dr. M. Shazib Faridi. I'm working as an associate professor in the Division of Urology, Department of Surgery at Hamdard Institute of Medical Sciences and Research, New Delhi. Well, moving towards the basic anatomy of the prostate gland. A prostate gland is a structure I hope you can make out. This is an urinary bladder, and just below the urinary bladder, there is an oval structure just below the urinary bladder, and between which a tube is passing. This tube is known as an urethra, and through which the urine passes from the bladder to the external world. And this organ is the main organ which we will be dealing today, known as an prostate gland. So a brief about what is prostate. Well, prostate is a walnut-sized gland at the base of the male urinary bladder, which surrounds the urethra. And its main function is it produces an alkaline fluid that provides the nutrition to the sperm. Well, prostate grows to its normal adult size in a man by the age of early 20s, and it further start growing in the by the age of mid 40s. Now, what happens? Yeah, so this is the male anatomy which I've already discussed with you. So just revising it again, this is an urinary bladder, below which a walnut-sized structure which we are dealing with today, which is the prostate gland, and this is the urethra passing in between the prostate gland. Now, what happens when this gland increases enlarge in size? So when this gland enlarges, it enlarges outwards also, it enlarges inward also. So when it enlarges outwards, the symptoms would be presented, but not much symptoms the patient can experience. But when this gland enlarges inside, then the problem occurs. Now, what is the problem? It compresses the urethra, and when it compresses the urethra, the urine starts stagnating here, and the patient will experiencing the symptoms which we known as lower urinary tract symptoms. We'll be discussing about in detail in further slides. So now, what can happen to the prostate gland? There are three most common conditions which a prostate gland can have. First and foremost is benign prostatic hyperplasia, in which the prostate gland increases or enlarges in size, but it is a benign condition. There could be prostatitis, which is known as inflammation of the prostatic gland, could be because of some infection. And this is another entity known as prostate cancer. So this one is a benign condition, and this one is a malignant condition of the prostate gland. Each condition affects the prostate differently. Now, so we are dealing today with the benign prostatic hyperplasia. It is in the top 10 of the most commonly diagnosed diseases in the man over the age of 50 years. 50% of men in their 50s experiences the benign prostatic hyperplasia symptoms. And this percentage or this incidence increases to up to 90% in the man of age 70 to 80 years of age. So briefly about what is exactly the benign prostatic hyperplasia. Well, because this is a patient-oriented classes, so I'll be dealing in the basic things which are required for a patient to understand. Well, hyperplasia means increase in the number of cells. So what happened? There is increase in the number of cells of prostatic gland. I have already discussed it compresses the urethra when it grows inside and it makes difficult to pass urine. It is not a cancerous condition because it is a benign condition. Yes, yet the patient can have bothersome symptoms and which can affect the quality of life. Yes, it can progress to more serious conditions, which are also known as complications associated with benign prostatic hyperplasia, and already discussed common in patients over the age of 50 years. So now these benign prostatic hyperplasia constitute of three basic words. Benign means it's a non-cancerous condition. Prostatic means related to the prostate gland. And hyperplasia, I've already discussed, it's increase in the number of cells. So commonly known as BPH. Benign prostatic hyperplasia can lead to prostatic outlet obstruction, bladder outlet obstruction. It means because of compression of the urethra, the urine is not flowing outside. So there is an outlet obstruction from the bladder, which leads to lower urinary tract symptoms. So does BPH means the patient has prostate cancer? No, BPH is purely a benign condition and it is not a prostate cancer. Yes, the symptoms of the patient of benign prostatic hyperplasia and the prostatic cancer is almost similar. Yet BPH can exist with prostate cancer. But as per se, BPH is not a prostate cancer disease. Now a few lines about the prostatic specific antigen. This is a serum marker which we use to screen the prostate cancer. Yet alone we cannot use this prostatic serum prostatic specific antigen levels to diagnose or BPH or prostate cancer, because PSA is a prostate specific marker. It is not a disease specific marker. It will not diagnose benign or malignant condition. So now what are the lower urinary tract symptoms which a patient will experience? So it is divided into two: storage or irritative symptoms. A patient can have increased frequency of micturition or frequency of urination. Patient can have urgency, he has to run to pass urine. A patient can have nocturia. As per the International Continence Society, if a person wake up after a sleep to pass urine for a single episode, it's regarded as nocturia. Then another is urgency incontinence. The patient can have severe urgency with the passage of urine. Now moving towards the voiding or obstructive symptoms. A patient can have poor urinary stream, hesitancy. It means the patient will, the initiation of the urine, it will take some time for the patient to initiate the urine. Intermittency, the patient can have urine, then it will stop, then it will again start coming out, then stop. So this is an episode of intermittency. Then straining to void, he has to strain it. The urine is not coming out, he has to strain, use his abdominal muscles to bring out the urine through the urethra. Then patient can have features of post-micturition dribbling. It means he has already passed urine, but then also he has few drops of urine which passes out. It could be and it can stain his clothes. And obviously when he will not pass urine, so there is a feeling of incomplete emptying of the bladder. Whether the BPH affects the quality of life, we'll see a few studies and let's see what the studies say. Many men who suffer from BPH have experiences a reduction in the quality of life. A study shows that up to 95% of men with moderate symptoms of BPH, they are unhappy and don't want to spend the rest of their life with these symptoms. Another study showed that about 50% of men suffering from BPH, they interfere with the one or other aspect of their normal life. Studies have shown that about 50% of men experiences sexual problems associated with lower urinary tract symptoms. And another important study showed that BPH also affects men's partner's quality of life, her daily routine, and the relationship between the two people. So this is an graph which showed how does the BPH affecting the quality of life. It is impacting of the quality of life immensely. About 35% of patients, they limit the fluid intake before bedtime because they have a fear that they have to run whole night in to pass urine. About 32% of patients, they avoid places where toilets are not available. About 30% of patients, they limit fluid intake before traveling. Maybe they're traveling in a bus, maybe traveling in the trains where toilet facility is not very good or not available. So they have to limit their fluid in fear of urination in between. About 27% of patients, they are not getting enough sleep because they have to wake up after 15 minutes, 20 minutes, whole of the night to pass urine. About 21% patient cannot drive in a stretch for 2 hours. In 15% of patients, they have avoid going to theaters, movies, churches, or any other places of social gatherings. About 13% of patients, they have avoid outdoor sports because of this problem. We have discussed who are the people who can get BPH, but in the age of by 50 years, 50% of patients can have symptoms of BPH, and this symptoms they gradually increases to about 80% by the age of 80 years. Now, what are the risk factors for BPH? Obesity, a body mass index of more than 30, and people who are not doing or performing exercise, they have increased risk of developing lower urinary tract symptoms because of BPH. Now, what are the potential medical consequences of BPH? If this problem continues and patient does not take treatment for this, then patient can experience urinary retention. He can have recurrent urinary tract infections. There could be a formation of bladder stones. Patient can experience hematuria. There could be overflow incontinence. And yes, when because of back pressure changes, the kidneys are hampered and patient can have decreased kidney function. So how we will diagnose a enlarged prostate? The most important is medical history and examination. The history of the patient with these lower urinary tract symptoms, then physical examination. If a patient have retention of urine, then can have a palpable bladder. We have to do a digital rectal examination to see the size of the prostate gland. We'll palpate the size of the prostate gland and how is the surface, how is the consistency of the prostate gland, and whether it is smooth or lobular. So it will give a brief idea about the prostate gland. Now, ultrasound is basically an extension of the medical examination nowadays. So ultrasound of prostate will help us in diagnosis the exact size. A good ultrasonologist can give any hypoechoic areas in the prostate gland, which will increase the suspicion of malignancy. Then a patient ultrasound will give you the homogeneity of the gland. It will tell us the complications, which I've already discussed, associated with it. And ultrasound can also help in telling about the how is the ureter, bladder, or any back pressure changes in the kidneys. Now moving towards the uroflowmetry, it Uroflowmetry is basically a procedure which helps us to diagnose the urinary flow. In this, we can see the peak urinary flow rate, average flow rate, and post-void residual urine. After the passage of urine, how much is the urine left in the bladder? So this will help us in telling us these investigations. Now moving towards the self-evaluation of symptoms. The patient can itself self-evaluate the symptoms with the help of a score made by American Urological Association, known as American Urological Association Symptom Index, or IPSS. IPSS is another symptomatic score. So dealing with a few slide about what is the American Urology Association symptom score. So it constitutes the 7 parameters, and another one is the quality of life. So it tells about, we have to grade it out, how much is how much points a patient has. So every single parameter has different points as per the condition. So first is, over the past month or so, how often have you had a sensation of not emptying your bladder completely? So if there's not at all, patient does not have this symptom, then the score is 0. If less than 1 in 5 times, 1, less than half the time, 2, about half the time, 3, more than half the time, 4, and almost always patient is not able, patient has a sensation of not completely emptying the bladder, then we'll give 5 points. Similarly, there are other parameters like, during the past month, how often have you had to urinate again? Less than 2 hours after you finish urinating. So there's increased frequency of urination. Similarly, the points are given. Another parameter is, during the past month or so, how often have you found you stopped and started again several times when you urinated? Means intermittency. Now, during the past month or so, how often have you found it difficult to postpone the urination? Whether the patient can postpone the urination. He can for some time he can postpone. If there's no availability of the toilet, so he can postpone for half an hour, 1 hour. So how often this patient can able to do it, or it's difficult to postpone the urination? Another parameter is, how often have you had a weak urinary stream or a poor urinary stream? And another parameter is, how often have you had to push or strain to begin urination? Is to strain to void. Similarly, how many times per night did you most typically get up to urinate? It means nocturia. How much time the patient has to go for nocturia? And another last point is, how much it affects the quality of life. So now moving towards, what are the treatment options available to us? First one is watchful waiting, then the medications, in-office therapy or therapy on the basis of OPD, and last one is surgery. So dealing each one of one by one. First of all, watchful waiting or medical therapies. So in which patients we can do a watchful waiting treatment option? First of all, a patient have mild symptoms. It consists of yearly examination and no active intervention, no medication, no surgery, only lifestyle modifications, such as dietary habits. He has to avoid oily red meat. He has to take fluid intake has to be restricted in the evening hours, not to take a lot of tea or coffee in the evening or night hours, and he has to start doing some exercise, walking or jogging. These are the lifestyle modification which patient has to introduce in their day-to-day activities. Yes, the side effect, every therapy has few other side effects. The side effects are, these patient can have the symptoms does not changes, or the symptoms may get worsened down. Now, moving toward the treatment option, which is very common nowadays, everybody is prescribing, every doctor is prescribing these medications. The first one is alpha blockers. Alpha blockers, these are the medications which block the alpha receptors present in the urethra, prostate gland, and the bladder neck. So these are basically meant for the people who have mild to severe symptoms. Obviously, provide relief of BPH symptoms, work almost immediately, and it's a proactive form of treatment. The side effects of alpha blockers are the patient can have hypotension. There could be a drop in blood pressure. Patient can have postural hypotension, can have lightheadedness, dizziness, or fainting, fatigue. And there's another important side effect which we usually see is nasal congestions. Patient can have retrograde ejaculation because these receptors, they are blocked, so bladder neck is not closed, and the semen which normally has to go outside through the urethra, it retrogradely go into the urinary bladder. Now moving towards another important medication, which is known as 5-alpha reductase inhibitors. These medications, the mechanism of action is they blocks the conversion of testosterone to dihydrotestosterone, which is an active metabolite. Dihydrotestosterone is an active metabolite. So it is used in the BPH patients. It relieves the symptoms of BPH. Side effects are because it blocks the active metabolite of testosterone, the chances of erectile dysfunction, impotency are there. There could be lower sexual drive or libido. Ejaculation disorders have been seen with this drug. So before moving towards another modality of treatment, sometimes we combine the medications. We combine both the medications for have a better results. It has been seen that if the prostate gland is more than 30 cc with lower urinary tract symptoms, both the medications should be combined for better results. So now, few lines about in-office BPH therapy or therapy on the OPD basis. Two most important therapies which are available nowadays is transurethral microwave therapy. In this therapy, what happens? The microwaves are produced, which leads to increase. The probe is inserted into the urethra, and it increases the intraprostatic temperature to about 40 to 45 degrees centigrades, which leads to ablation of the prostatic gland because of heat and excess of prostate tissue ablated. Similarly, in transurethral needle ablation, in this what happened? A low level of radio frequency energies are used. Similarly, a probe is inserted into the urethra, and at the level of prostatic gland, the radio frequency is targeted. And because of this radio frequency, the intraprostatic temperature increases about 110 degrees centigrade, leads to coagulative necrosis of the prostatic glands, and the prostatic gland tissue ablated down. So now, how this in-office treatment or the OPD basis therapies work? It's basically a pre-procedure preparation of about 15 to 20 minutes. Medications are given for relaxation and comfort, mostly done in local anesthesia. So no GA or spinal anesthesia required. Or nowadays we can have prosthetic nerve blocks, which eliminate the discomfort completely. And studies have shown that the pain is very easily tolerable, and the points on the pain scale is about 2 to 3. Procedure time is less than 30 minutes. Patient is kept for about 30 to 45 minutes for observation, and then we can discharge the patient maybe on the catheter, and after 2 to 3 days the catheter can be removed. I've already told patient can go home shortly after treatment. Urinary catheter can be placed for 2 to 3 days. Patient return to normal activities within 24 to 48 hours. The symptoms are improved generally within 8 to 10 weeks of the treatment, and it lasting it lasts the relief of the symptom lasts and patient have improved in symptoms. So what are the in-office therapy advantages? Effective at relieving symptoms, results are long lasting, eliminate the need for chronic medications, very low risk of any injuries and invasive surgical procedures. It's OPD based procedure, so patient completed in 1.5 hours. So patient can return to his home early and can perform his activities in 24 to 48 hours. And side effects are obviously less. So a few possible side effects. I've already told every surgery has few other side effects. So what are the side effects of transurethral microwave therapy and what are the side effects of transurethral needle ablation? So a patient can have hematuria, dysuria, clots in urine, obviously pain for difficult urination. There could be some rectal irritation because just posterior to urethra, the rectum is there, so patient can have some rectal irritation, sometimes temporary inability to control urination, but these symptoms gradually subsides, inability to discharge semen in orgasm initially, and inability to achieve or maintain erection. But these all symptoms, this subsides gradually in few days. Similarly, side effects for transurethral needle ablation, there could be obstruction in passing urine, patient can have hematuria, pain, urgency, sometimes increased frequency of maturation, and can have some few episodes of urinary tract infection. So now moving towards the surgery, the basic invasive procedure, which is a surgery. So there are a few more. These surgeries divided into two parts. One is minimally invasive surgeries, another is an open surgery. So in the minimally invasive surgery, we have two options. One is TURP, transurethral resection of prostate. In this, what we do, a probe is used in which electricity is passed, which increases the temperature of that metal band and cuts the prostate tissue into small chips. Used for patients who are not satisfied with medications, have moderate to severe symptoms. Obviously, the patient has to undergo in spinal anesthesia or sometimes in general anesthesia. Post-operative hospitalization is required, maybe 2 days or more than 2 days. The symptom, if performed rightly, the symptoms are relieved. The prompt relief in the symptoms demonstrated improved Qmax and obviously prostate volume also decreases. The side effects are the entity known as TUR syndrome, in which what happens, because of increased absorption of the liquid, there is relative hyponatremia and patient can experience headache, lightheadedness, dizziness, and there could be increased BP, bradycardia. Then patient can have urinary retention. If there's injury to the urethra strictures are formed. Most commonly in the QRP, the urethral strictures are formed at some meatal part. Then patient can have bladder neck contractures. Then retrograde ejaculation. Obviously, when the bladder neck is resected out, there's a high chance of bladder neck ejaculation. And obviously, patient can have hematuria required. If there's massive hematuria, then patient requires transfusion. Another important minimally invasive procedure is laser therapy or HOLEP, which stands for holmium laser enucleation of prostate. In this, the holmium laser vaporizes away whole of the prostate tissue. Let us say it provides symptomatic relief. Patients start have prompt symptoms improvement, very minimal blood loss. Side effects are almost similar of TURP, retrograde ejaculation, urgency, dysuria, hematuria, or retention. So now moving towards another treatment option, which is an invasive procedure known as open prostatectomy. It is typically performed in patients with a large prostatic volumes of about 80 to 100 ml, effective in men with large prostate volume. Patients have, if the patient have large prostate volume with stones, bladder diverticulars, then we have to treat both these conditions simultaneously. So open prostatectomy is a better option. But yes, associated with side effects, patient require a longer hospital stay, risk of blood loss is more. So patient require a greater chances of greater transfusion rates are more than the minimally invasive procedures. Yet, the open surgery has advantages also: prompt or immediate symptomatic relief, long history of success, and can eliminate the need for chronic medication. So now, what is the winning solution? See, urinary symptoms are a normal part of aging. There are treatment options that can help you to restore your quality of life. If you are dissatisfied with your current therapy, discuss with your urologist and move to another therapy which suited to you. So these are the references which I have got it down in my presentation. And thank you very much. I like to answer if there's any queries. Thank you.
Thank you very much, sir. So there are no questions till now, but can you wait for 1 to 2 minutes more for the delegates if there's any questions comes? So, still there are no other questions. So, with your permission, shall we conclude?
Yeah, sure.
Yeah. Thank you very much. On the behalf of organizer, I would like to thank you for your informative and educative talks. Thank you very much for your valuable time.
Thank you.
Thank you. So, from here, I'm ending this meeting.
Sure.